Hi guys, welcome back to week 9. We are now in the module for hematology. In this module, we'll be talking about common hematological and immunological complaints, some hematological disorders, immunological disorders, and infectious disorders. So this is a brief PowerPoint to just do a nice thorough review of the topics that you were assigned for your readings. I would suggest highly that you have the printed PowerPoint that is corresponding with this module. It's uploaded within the module, corresponding with this lecture, as well as have your textbook available, because there are definitely pages, tables, diagrams that I am going to refer you to that I would really think would be very helpful for you to review as we are going through this lecture. So here we go. There's about 30 slides. So this should take about an hour. So again, these were the topics of discussion that you were assigned for your readings, including common hematological and immunological complaints, the disorders, immunological disorders, infectious disorders. So these were the assigned readings. So please make sure you review them, as well as the supplementary videos from YouTube to go over a few of the disorders that I thought would be helpful in terms of visual guidance.
It's 5 o'clock.
Practice guidelines that you were assigned to review from your CASH textbook included systemic disorder guidelines, chronic fatigue fevers, HIV, autoimmune thrombocytopenic purpura, iron deficiency anemia. We're going to be going over all the anemias, but I would highly suggest you look at your CASH textbook on page 619, table 17.1, to differentiate microcytic hypochromic anemia from other types of anemia, because keep in mind, iron deficiency anemia is your top type of anemia that you will be treating specifically in primary care. You were to review your lymphadenopathy guidelines, causes by site of enlarged nodes, as well as pernicious anemia. Chapter 21, you went over your rheumatological guidelines. You looked at your guidelines for fibromyalgia, gout, osteoarthritis versus rheumatoid, Raynaud's phenomenon, including the drugs that induce Raynaud's. So please look at page 752, table 21.1 in your CASH textbook. We also had you look at systemic lupus erythematosus, SLE, and I just wanted to make sure you review the fundoscopic exam findings on page 759. Also, pharmaceutical therapy for giant cell arteriolitis, also known as temporal arteriolitis, really important for you to review. So please look at that, as well as page 763 for vitamin D deficiency. Review your diagnostic tests, differential diagnoses plan, and pharmaceutical therapy. So common hematological and immunological complaints, we'll start with basic things such as bruising. And here you have an integumentary manifestation of extravasated blood, which is basically, you see this area of blood manifest on the skin. It's a discoloration of skin attributed to a local interstitial pool of erythrocytes. The bruise sets off a local inflammatory event that includes macrophage invasion and histamine release. The macrophages engulf the red blood cells to clear the extravasated blood. Look here at this table. I listed this table just to remind you of medications that could possibly be the cause of bleeding or bruising. Some of those drugs include Eliquis, Pradaxa, Lovenox, heparin, Xarelto, Coumadin, aspirin, Plavix, some fish oils, selective serotonin reuptake inhibitors, and alcohol as well can cause thrombocytopenia. And then you have Tegretol for your bipolar disorder, your psychiatric med, quinine, thiazide diuretics. These are all medications that can cause bleeding or bruising. So make sure when you are doing a workup of your patient, you're looking at their medication profile to ensure that that is not the cause. Here is an algorithm to help kind of differentiate and diagnose abnormal bleeding or bruising. The first thing here is you want to rule out trauma or medications as a possible cause, and you want to reflect back on that table in the previous slide to just make sure you rule that out. Clinical clues to guide your workup. You want to make sure you're just looking at the symptoms that they're manifesting, and then take it from there, looking at this algorithm. Number 6, slide 6, we have fatigue. So basic complain of tiredness that cannot be explained. Fatigue is a very vague symptom. There are multiple differential diagnoses of chronic fatigue. So you want to kind of familiarize yourselves with, possibilities. Acute fatigue is most often associated with viral or bacterial infection. So you want to rule out infection pretty much immediately when you hear fatigue. You want to consider underlying medical conditions, hematological abnormalities, specifically anemia as well as cancer. Those are definitely high, symptoms with high fatigue in them. Functional fatigue, we want to also rule out depression as well as anxiety. When you're looking at fatigue, the symptom of fatigue, we're definitely doing a workup with the patient to really assess, how are they sleeping at night? What's going on? What are their sleep habits? What is their routine? And are they staying asleep throughout the night? Do we need to rule them out for sleep apnea? Fatigue is a very broad complaint. Please make sure you do your due diligence, really do a thorough physical exam, review of systems and HPI, as well as, really consider your differential diagnoses and your genetic history, any kind of medical history, both within the patient as well as their family history. Fever, another very common immunological complaint. Fever includes a temperature elevation above a patient's normal baseline, in which the etiology could vary. It may result from any pathology and is often multifactorial. So basically that means it can result from pretty much any kind of diagnoses, and it could possibly have multiple differential diagnoses. The primary care practitioner who's ruling out this complaint should approach diagnostic decision-making for fevers with several large etiologic categories in mind, such as infection, malignancy, non-infectious inflammatory diseases like rheumatological disorders, any kind of drug or environmental exposures, as well as thromboembolic disease and even fictitious causes. Here in this chart right here, table 1, I give you some various reasons or causes of unknown origins for fevers. So if we have bacterial infections, we want to look at osteomyelitis, pyelonephritis, our upper UTIs, abscess, infective endocarditis, tuberculosis, cat scratch disease, typhoid fever versus viral infection. We have Epstein-Barr virus, Lyme's disease, cytomegalovirus, enterovirus, adenovirus, versus malignancy, where we worry about cancer, where we're thinking and considering leukemia, lymphoma, or neuroblastoma. We have autoimmune, where we're concerned about systemic lupus erythematosus, where we're going to get into that later on in our module here. We also could consider inflammatory bowel disease, idiopathic arthritis, and then other miscellaneous things could be Kawasaki's, drug fever, or just a periodic fever. But there's usually, at some point, there will be an underlying cause. I mean, to say that there's, an unknown etiology, that seems kind of strange. There's got to be a reason that the patient is running fever. So you really want to do a very thorough workup and diagnostic workup. Another common complaint is lymphadenopathy, which is basically any organ abnormality or swelling of any particular enlarged lymph nodes. It could be acute, where it's tender regional nodes, or maybe chronic, where it's non-tender. We have a lot of different lymph nodes, and basically it's just a large excess accumulation of lymph fluid in the area. The term lymphadenopathy is used in clinical practice to designate any abnormality of lymph nodes, and in particular, enlarged lymph nodes. Lymphadenitis is a term that suggests that inflammation is the cause of the lymph node enlargement. Lymph node enlargement may be regionally or systemically associated with inflammation. And if the inflammation is regional, the lymph nodes that are proximal to a site of infection will show enlargement. If the disease process is systemic, lymph nodes in 3 or more sites that are dispersed across the body may become enlarged. So I'm going to repeat that, guys. I really need you to understand that. So lymph node enlargement may be regional or systemic, associated with inflammation. If the inflammation is regional, the lymph nodes that are proximal to a site of infection will show enlargement. If the process is systemic, meaning it's all over the body, lymph nodes in 3 or more sites that are dispersed across the body may become enlarged. An example of regional lymph node enlargement is cervical lymphadenopathy associated with pharyngitis. An example of systemic lymphadenopathy, meaning it's all over, is HIV infection, in which there may be lymphadenopathy in 3 or more extrainguinal lymphatic chains. Lymphadenopathy follows the course of the underlying disease. Thus, lymph nodes may be acutely or chronically enlarged depending on actual disease pathology, meaning how far along are we in the disease process, right? So that's going to really dictate the severity of how bad our lymph nodes are affected. So the disease pathology, the natural history of the disease, as well as the duration of the disease will impact the level of lymphadenopathy. Acute infection often leaves the regional nodes tender to touch. Chronically enlarged lymph nodes may be non-tender. In my next slide here, I gave you a picture just to remind you of where exactly all these different lymph nodes are. And here in this table, it gave you the mnemonic Miami to do a differential diagnosis of your lymphadenopathy. So Miami being malignancies, I for infections, A for autoimmune disorders, M for miscellaneous unusual conditions, and then I for iatrogenic causes like medications or serum sickness. But make sure you review this table, this figure right here of this guy, to make sure you know where all your different lymph node possible lymphadenopathy could occur. It also gives you the associated areas of what could be affected. So remember, determining causes of lymphadenopathy, there are multiple differential diagnoses for lymphadenopathy, and it depends on the location of the involvement, the patient's characteristics, and of course the associated findings. Neck masses, for example, involve a differential that is based on a node location in the neck, the age of the patient, and associated morbidities such as tobacco use. The clinician should distinguish between slow growth in nodes and rapid or acute onset of lymphadenopathy. Acute onset is characteristic of inflammation or acute infection, whereas slow-growing nodes in the neck suggest neoplasms such as lymphoma. However, there are exceptions. For example, a young patient with no history of tobacco or alcohol use may present with a slow-growing cervical lymphadenopathy, but the possibility of neoplasm is minimal in a patient of this age and with this history. Nonetheless, an adult older than age 70 years with even a remote history of tobacco use is likely to be diagnosed with lymphoma if there is slow-growing neck lymphadenopathy. Thus, the patient's age is an important consideration in the differential diagnosis of neck lymphadenopathy. I'm going to be honest with you guys, age is a important consideration in all differential diagnoses, no matter what it is. I'm going to tell you, when 65 and up, things start to change pretty drastically. So you really want to consider age when it comes to different causes and differential diagnoses, no matter what it is you're looking at. In this particular table here, we have clues and initial testing to determine the cause of lymphadenopathy. So you want to look at historical clues. Your fever and your night sweats, weight loss, or node located in the supraclavicular popliteal or iliac region, as well as bruising and splenomegaly. We're looking at suggested diagnoses of leukemia, lymphoma, or a solid tumor metastasis. Here's your initial testing, your CBC, your biopsy or bone marrow biopsy imaging with ultrasound and computed tomography may be considered, but should not delay referral for a biopsy. So again, a lot of these patients, when you're even considering these things, you're already getting them referred to either hematology, oncology, depending on what kind of things you're finding in your differentials and your diagnostics. But again, you need to know what the process is here in terms of testing, in terms of treatment plan, in terms of diagnostics, because you are going to be consulting with these other physicians, and you want to make sure that you guys are all on the same page in terms of guidelines and basic standards of care. All right, hematological disorders, please look in your primary care textbook, review page 962, table 61.1, the classification of anemias. That's so helpful. I also developed in this PowerPoint a table for you to review everything, just to make sure you're really able to differentiate and diagnose the different types of anemia. But here in your classification on your table 61.1, you're looking at your different anemias based around, they kind of classify the anemias based around microcytic, hypochromic, versus normochromic. They kind of classify it a little differently. I like their chart, but you know, whatever chart you need to make sure you're understanding the differentials, you use those. Again, I put another chart in a few slides from here, but anyway, let's talk about microcytic anemia. So the causes of microcytic anemia could be iron deficiency anemia, anemia of chronic disease, thalassemia, or sideroblastic anemia. And it's really helpful to remember the different types of anemia based around microcytic versus normocytic. Okay, and here is again another chart to differentiate the different types and classifications of anemias. So the evaluation of anemia is extremely common in clinical practice, and it is one of the most common laboratory abnormalities encountered in the primary care setting. Anemia can mean any of several problems that involve suboptimal red blood cell number or function. The diagnosis suggests low hemoglobin, low hematocrit, and or a low number of red blood cells. All of these problems involve a reduced amount of oxygen circulating in the body because red blood cells carry oxygen to tissues and cells. The World Health Organization, or the WHO, identifies anemia as a hemoglobin of less than 13 in men, or less than 42% hematocrit in men, and less than 12 or less than 30% hematocrit in women. Slightly higher normal ranges of hemoglobin and hematocrit values are considered standard in developed versus underdeveloped regions of the world. The evaluation of anemia may be uncomplicated unless the patient has comorbidities that can impact the evaluation of anemia, including the interpretation of lab results. Past medical history, family history, concurrent medical problems, and predisposing risk factors for anemia are important to consider in the evaluation of all different types of anemia and other hematological disorders. It is important that you determine whether the anemia is due to decreased red blood cell production, maturation defects of red blood cell precursors, destruction or hemolysis of red blood cells in the peripheral blood, or even worse, worst case scenario, acute blood loss or danger, hemorrhage, okay? Microcytic anemia, which we're talking about here, is a category of anemia based on the small size or micro of red blood cells, cytic, okay? So when you're looking at microcytic, you're looking at small size red blood cells. It has been linked to nutritional deficiencies, particularly a deficiency in dietary intake or GI uptake of iron. That's why we get iron deficiency as your most common microcytic anemia. The small cells of red blood cells is identified via the mean corpuscular volume, MCV. Okay, so here we have it, normocytic anemia. Normal MCV would mean that it's a normal size, okay? So microcytosis therefore refers to an MCV value of less than 80 FL, okay? So mean corpuscular value that's less than 80 would be considered microcytosis. Then we have normocytic anemia, which is defined as anemia associated with normal sized red blood cells, which is an MCV of 81 to 99. Yes, guys, you do need to really memorize these numbers. They are really, really important, both for clinical practice, your boards, your exams, life. I can't even tell you, like these numbers and these different types of anemias are going to haunt you for the rest of your practice. So it's just really in your best interest to make sure you're memorizing and differentiating the different types of micro versus macrocytic anemias, okay? So back to normocytic anemia, which is your normal red blood cells, is defined as an anemia associated with normally sized red blood cells, again, MCV 81 to 99, although normal ranges vary with age. Many forms of normocytic anemia have normally shaped red blood cells as well, although some conditions are recognized by typical abnormal morphological findings on a peripheral blood smear. Most commonly, this type of anemia, normocytic anemia, results from chronic disease states that lead to a hypoproliferative anemia. However, acute blood loss, hemolysis, and volume overload are other important etiologies of normocytic anemia. However, most of the time, this is associated with your chronic disease state. Then we have macrocytic anemia. Macrocytic, so we have a different, each type of anemia is based around the cell type, has different types within it. Okay, so remember your umbrellas. So your umbrellas are microcytic, normocytic, macrocytic, and then you have sickle cell and thalassemia. So macrocytic anemia or megaplastic anemia. Okay, so remember that macrocytic or megaplastic is defined as anemia with an MCV equal to or greater than 100 FLs. These anemic states are typically normochromic and may be normoblastic or megablastic with large erythroid precursors. Macrocytic anemias result mostly from defects in DNA metabolism or changes in red blood cell membrane structure. Then we have, so in macrocytic anemia, we're looking at potential causes or differential diagnostics of vitamin B12 or folate deficiency, liver disease, malabsorption, alcohol use. So alcohol use, you're mostly going to be seeing macrocytic anemia, which would be vitamin B12 deficiency or pernicious. And then we have, of course, hypothyroidism. So again, if you have a hypothyroid patient with hypothyroidism, you definitely want to rule them out for macrocytic anemia. So it could be any of these three, okay? Now we have sickle cell anemia. Sickle cell anemia is an autosomal recessive disorder. The disease is caused by a point mutation in the DNA sequence of the gene for the beta hemoglobin chain, termed the hemoglobin S gene. Hemoglobin S gene, very important for you to remember in terms of sickle cell, resulting in a marked hemoglobinopathy in which intracellular hemoglobin molecules form abnormal polymers that cause gross sickling of red blood cells under hypoxic conditions. So that's important to know. Hypoxic conditions will equal a sickle cell crisis, okay? It is therefore diagnosed by the detection of sickle cell shapes, cells on a peripheral blood smear, a positive family history, current painful episodes of vaso-occlusive pain, and a pattern demonstrating mutated hemoglobin S on a hemoglobin gel electrophoresis profile. Sickle cell anemia, when these patients are in crisis, they are in severe pain. A lot of the times these patients need to be hospitalized to manage these crises. They usually get pain in the back, chest, abdomen, or extremities unrelieved by rest or position. It is very painful. These patients are born with this. It's a genetic disorder, and to see children and babies in sickle cell crisis is horrific. It is so sad. So getting their pain under control is priority. So here is a chart I created for you guys really to help you differentiate the different types of anemia, what each one kind of how it's differentiated in terms of genetics or whatever commonalities, treatment. Very important that you look at what the red blood cell changes are in terms of differentiating each type of anemia. Everything you see here in yellow or bolds are your diagnostics and are the gold standards for the exams to diagnose as per the guidelines. So your iron deficiency, you're going to find your ferritin, serum iron are decreased, your TIBCs are elevated, your RDWs are elevated. Can look at what's similar here. Your thalassemia minor and your sickle cell anemia are both diagnosed gold standard by your hemoglobin electrophoresis, okay? Also, I want you to look at your pernicious and your folate deficiency. They both are exactly the same in terms of the red blood cell changes. So you need to make sure you're differentiating your diagnostics to differentiate which type of anemia it actually is. Keep in mind your vitamin B12 deficiency, you're going to have paresthesias and numbness. You're going to find that your patients are complaining about that. If your patients start to complain of numbness in their fingers and toes, this is one of the first things you want to rule out, vitamin B12 deficiency. So when you're looking at their CBC and you're seeing these different red blood cell changes, that's when you start to consider any type of anemia, all right? Keep in mind when we say the word microcytic, you want to think small versus macrocytic. Another word you want to make sure you're differentiating and just really kind of understand when you look at it is hypochromic. Hypochromic just means pale red blood cells, pale red blood cells. These words are clues to differentiate each type of anemia. And again, I can't stress enough, you really need to know how to differentiate them. Make sure you're understanding what anemia is microcytic versus macrocytic. I tried to, kind of put them together. So your micros are your iron deficiency, your thalassemia minor, then your macros are your pernicious anemia, folate, and vitamin B12 deficiency. So that's how you learn how to remember these things. You group them together based on their RBC changes. Make sure you know your gold standards in terms of evidence-based practice and what the standards are to diagnose these types of anemia, because that will guide you in terms of your treatment as well. In terms of differentiating, here is a nice algorithm just to help, again, guide you in terms of differentiating what the causes are and what other differential diagnoses you want to consider. Look at your values. So your MCV microcytic is less than 80. Your MCV normocytic is 80 to 100. Your MCV macrocytic is greater than 100. These would include megaplastic and non-megaplastic anemias. All right, make sure you look at page 984. I want you to review table 61.2 for the types of leukemia and the general treatment considerations, as well as page 992 for patient education regarding leukemia. The first thing I wanted to talk about was polycythemia. Polycythemia involves an increase in the erythrocyte number or concentration, which results in an increase in blood viscosity. The disorder may be either relative or absolute, and a hematocrit greater than 51% in women and 54% in men is characteristic of this condition. The term polycythemia is somewhat misleading, as it literally means too many blood cells, poly meaning many, and cythemia meaning blood cells, rather than too many erythrocytes in particular. Nevertheless, the name is only associated with an increase in erythrocytes, okay? Causes of relative polycythemia include decreased fluid intake or dehydration, increased fluid loss from the body, and extravasation or redistribution of vascular fluid into the tissues. Absolute polycythemia, on the other hand, may be caused by either primary or secondary mechanisms. Primary would involve proliferation of stem cells and is termed as polycythemia vera, versus the causes of secondary absolute polycythemia include Cushing syndrome or erythropoietin secreting tumors and chronic hypoxia. Then we have leukemia. Leukemia, we know, is a neoplastic disease of malignant chemotypoetic stem cells that differentiate and proliferate according to specific lineage trajectories that distinguish the types of leukemia as either acute or chronic. Further classification of leukemia specifies the stage of development and type of white blood cell that is involved in the malignant transformation. So that's a big distinguishing factor in the different types of leukemia, guys, is your type of white blood cell. The involved leukocytes proliferate and occupy space previously filled by non-malignant cell lines. Thus, one significant outcome of the malignancy is the suppression of non-malignant blood cells. So in terms of signs and symptoms of leukemia, again, please look at your page 984, 992. In terms of acute leukemia, we're looking at bone and joint pain, gingival bleeding in your gums, fever, chills, and easy bruising, versus chronic leukemia, which would include fatigue, night sweats, low-grade fevers, and splenomegaly. Here is a chart that I wanted to include just for you to reference in terms of really understanding and differentiating the major subtypes of leukemia. Look at your ages here. Pay close attention to the typical groups affected and the ages. For instance, CLL, 85% of your new cases occur in patients greater than 65 years old. So when the question tells you signs of leukemia, make sure you're looking at the patient's age to help you differentiate which subtype of leukemia the patient likely has. Okay, adults, for 80% of acute leukemia in adults, this is what acute myelogenous leukemia is accounted for that. Again, older adults are more likely to be diagnosed with chronic lymphocytic leukemia, versus acute lymphoblastic leukemia tends to affect people less than 20 years of age. So when you're really trying to, remember these and differentiate them, I would classify them based around the ages. And it's in this chart, they literally give it to you, ALL, AML, CLL. Remember, when you're looking at subtypes of leukemia, they're likely going to be referred to by their initials. So your subtype would be ALL leukemia, AML leukemia, but I'm looking at ALL and I'm like, oh yeah, ALL is most likely children and young adults because 53% of the new cases occur in people less than 20. So I'm just going to kind of put that in the back of my head. ALL is associated with younger people. AML is associated with adults versus CLL is associated with adults who are 65 and up. Okay. Just different studying tips, ways to remember things, differentiate things, and really solidly actually retain this information. All right, so immunological disorders. The book goes into allergic reactions, in which are immune-mediated reaction to foreign environmental allergies. You're going to want to look at page 994, table 62.1 for your 7-step treatment on anaphylaxis. I have the slide in here, but I always feel like it's clear to look at these types of things actually within your textbook versus printing them on these small little slides. Then we also get into rheumatoid arthritis is another immunological disorder. You're going to want to look at page 1007, table 62.1, just looking at your disease modifying anti-rheumatic drugs specifically used to treat RA. You know, we get into arthritis in this particular module in a few slides. I'm going to get into the different types of arthritis and making sure you're pinpointing the different types of arthritis and the differential classic symptoms that patients present with to help you differentiate whether it's rheumatoid versus osteo. Okay, so back to management of anaphylaxis in the emergency department. Again, this is in your textbook. Make sure you're looking at this and really understanding it. So when you're managing anaphylaxis, you know, most of us are, you know, a lot of us are not going to be working in the emergency department. That's not our plan as NPs. I never planned that when I was in school. That's never something I wanted to do. But that being said, keep in mind your practice, your standard of practice, you're expected to know how to manage this regardless of whether you work in an emergency department or not, so that you know how to react, even if you're in a facility, anywhere. It doesn't really matter. A code is called, somebody's in an anaphylaxis, having an anaphylaxis reaction. You are, as a nurse practitioner, need to know how to handle it. So signs and symptoms of anaphylaxis would include an airway obstruction, bronchospasms, or hypotension. Immediate action would include adrenaline IM. And the big thing you need to know about administering adrenaline IM initially is it needs to go in the lateral thigh. Okay, that's very important. So remember, lateral thigh for your immediate action of adrenaline in the course of managing anaphylaxis. So whether it's adrenaline, epinephrine, again, upper lateral thigh. Here's the 7-step treatment for anaphylactic. Again, this is in your book. You're going to want to administer the epinephrine into the upper lateral thigh in a supine position with the head below the heart, if possible, because remember, we want to kind of put that patient supine and in reverse Trendelenburg to allow the blood to go back to the brain and heart because we need to prioritize those organs getting perfusion. We want to repeat epinephrine every 5 to 15 minutes as required by clinical presentation. If the patient is hypotensive, we want to position the patient supine with feet elevated. Again, reverse Trendelenburg. Step 3, support bronchodilators, administer albuterol via nebulizer. Step 4, if they're in laryngospasm or pulmonary arrest, we're going to perform an emergency endotracheal intubation, and of course, provide respiratory support. Step 5 would be to start IV fluids with normal saline or Ringer's lactate solution to maintain the blood pressure greater than 90 mm's. Step 6, we want to make sure the patient is conscious and without laryngospasm. Administer your Benadryl to relieve any cutaneous symptoms. H2 blockers may be added if the GI symptoms are present. And then step 7, we want to transfer the patient, of course, to acute care emergency center for continued support and observation, as well as add any kind of corticosteroids, IV or PO, to prevent any late phase anaphylactic reactions, which may be as severe as early phase reactions. Meaning, a lot of times research has shown that a patient who has an anaphylactic reaction and is treated, within a few minutes, they may actually have another reaction. So you have to be very conscious and have those, have the monitoring as well as the medication ready to go just in case. So like I said before, we want to make sure you're differentiating the different types of arthritis. It's very important to be able to differentiate between osteoarthritis as well as rheumatoid. Keep in mind, rheumatoid is a chronic progressive systemic inflammatory disease that primarily affects the synovial joints, although it can and may affect many organ systems. Structural deformities can cause some serious emotional as well as physical trauma for the patients, which is very common as rheumatoid progresses. My grandmother actually has rheumatoid, and it started in her 20s, and now she's in her late 80s, and she has become completely bedbound because of the contractures in her hands and feet as the disease has progressed. Healthy People 2020 has 3 objectives related to this chronic debilitating condition, which includes increasing the proportion of adults with chronic joint symptoms who have seen a healthcare provider for their symptoms. Also increasing the proportion of adults with physician-diagnosed arthritis who have had effective evidence-based arthritis education as an integral part of the management of their condition. And number 3, reducing the proportion of adults with the physician-diagnosed arthritis who find it very difficult to perform specific joint-related activities. So again, we are getting standards from the CDC and Healthy People 2020 in regards to managing this condition because it does affect a lot of people. So keep in mind the CRP blood test is a non-specific method for evaluating the severity and the course of the inflammatory process. CRP is normally less than 0.8 and is typically elevated in rheumatoid arthritis before treatment. Failure to decrease the CRP level after initiating treatment may thus indicate a lack of efficacy of the therapeutic agent or the presence of an underlying infection or tissue necrosis. Therefore, your CRP should be monitored to determine the effectiveness of therapy. Your erythrosedimentation rate or your ESR may follow the same pattern during treatment and may serve as a less technically involved and therefore a less expensive and more widely available alternative test of inflammation compared with CRP. However, many clinicians question the utility of the ESR as an elevated value is highly nonspecific and can be subjective. So the main gold standard is to really monitor that CRP with rheumatoid. So we're going to do a lot of labs, and you're going to be making sure that you make sure the patient is following the scheduled laboratory evaluations. Standardized and validated disease assessment tools may be completed by the clinician at each visit to assess how well treatment interventions have achieved the targeted goals of low disease activity and complete disease remission, commonly known as treating to target in terms of rheumatoid. Keep in mind, rheumatoid is the most disabling type of arthritis. The joints, as well as the lungs, eyes, spleen, skin, and heart may be affected. The big thing you want to remember in terms of rheumatoid is it's morning stiffness that lasts longer than an hour. It's swelling in 3 or more joints. It's swelling of the same joints on both sides of the body, such as both knees or both wrists. And joint tenderness, warmth, or redness is very common versus osteoarthritis. So keep in mind, osteoarthritis is the most common type versus rheumatoid is the more disabling type. Osteo is joint pain and stiffness in the hand, knees, etc. Finger joints with knobby growths and swollen joints sometimes. And then we also want to make sure we're differentiating between gout, which is sudden intense pain in a specific joint, often in the big toes. Usually they're swollen, red, and purple. Attacks can last hours to days, versus ankylosing spondylitis. This type of arthritis mostly affects young men between the ages of 15 and 45. So again, keep in mind which type of arthritis is differentiated based around the type of patient. So rheumatoid is the most disabling. Osteoarthritis is the most common. Gout is usually common in men over 30 versus ankylosing spondylitis is more young men between 15 and 45. This ankylosing spondylitis is more stiff backbone, lower back pain, stiff bent posture, breathing problems, and swelling of the iris of the eye. Those are your typical signs and symptoms of ankylosing spondylitis. So, if we're getting into arthritis and your patient is really starting to become affected by it and it's really going to need management, of course, you're already going to have consulted and referred your patient to a rheumatologist to make sure they're getting the best treatment and education that they can. These are chronic things that unfortunately don't go away, but they can be managed very effectively so that the patient's life is not disabled. And you want to get the management done as early as possible. So just make sure you are referring and getting these patients followed up with. Again, you need to know your causes, risk factors, signs and symptoms, as well as your basic standards of care and treatment guidelines to make sure you and the rheumatologist are doing due diligence for your patients. So remember, the primary care practitioner, or you yourself, the NP, should refer the patient to a rheumatologist if initial management, including aspirin or NSAID therapy, fails. So we're going to start these patients on aspirin and NSAIDs or both, whatever. And if it fails, that's when we want to make sure, okay, we're past the point of like over-the-counter stuff. We need to really start looking at what's going on with this patient. The rheumatologist is the one who's responsible for initiating therapies such as methotrexate and other DMARDs, including newer biological agents. So co-management may mean that the rheumatologist will evaluate the patient twice each year, once stable or more frequently, as signs and symptoms necessitate. In particular, specialist input is typically required to effectively treat to target, okay, because they're really honing in on symptom management, and education in terms of how the patient should be managing their day-to-day pain and activity. Okay, immunologic disorders, we're going to get into chronic fatigue syndrome and fibromyalgia, as well as Sjögren's syndrome. So Sjögren's syndrome, or SS, is a chronic inflammatory autoimmune disorder caused by exocrine dysfunction. It presents as dryness in all areas of the body. Please do watch the supplementary video I posted under your module to get a good visual review of this particular syndrome. So again, it presents in dryness in all areas of the body where there are exocrine glands associated with mucous membranes, most notably the salivary and lacrimal glands, so your mouth and your eyes. However, SS has the potential to affect a wide array of organ systems, including the skin, lungs, kidneys, and heart. In addition, the hematopoietic system may be affected with propensity for lymphoma. So diagnostic test of SS is diagnosed via clinical and laboratory findings rather than identification of a single causative agent. Clinical diagnosis of SS syndrome includes 6 defining characteristics, or 6 defining criteria. So the first one would be inadequate tear production. So that's, again, they're dry. They're not producing enough tears. Signs of corneal epithelial damage from dry eye. And you would do this by fluorescent staining or slit lamp examination. Decreased saliva production, so super dry mouth, cotton mouth. Lymphocytic infiltration of labial salivary gland tissue on histopathology following a labial gland biopsy. The closest test to so this is one of the closest tests to a gold standard for diagnostics, just as a side note. Number 5 would be impaired salivary gland function. Number 6 would be autoantibodies, including an anti-Ro or an anti-La. So 4 in 100,000 people have this syndrome. Please review page 1014 for diagnostic tests to diagnose Sjögren's syndrome. Remember to know your 6 defining criteria. Same thing with fibromyalgia. There are specific diagnostic criteria. I believe it's 13, if I'm not mistaken. Anyway, please make sure you look at page 1011 for your diagnostic criteria. It's table 62.1. Okay, so with the diagnostic criteria for fibromyalgia, just please make sure you understand that there's two different types of criteria that are involved with diagnosing fibromyalgia. Number one, you need to look at the history criteria and the history of where their pain is, where it, which side of the body it affects, or if it's considered widespread. The next thing you need to look at is the actual pain criteria itself. They have to have pain that exists in at least 11 of 18 tender points on the digital palpation. So basically, you're going to go around on this patient and digitally press or palpate on these different tender points. And 11 of those 18 points need to be tender in order for them to have the diagnostic criteria to actually diagnose them with fibromyalgia. So make sure you are aware and understand these different points and the criteria that's associated with the diagnostics for these particular syndromes. Okay, another immunologic disorder to make sure you're aware of and understand the criteria for diagnostics would include systemic lupus erythematosus. SLE is an inflammatory autoimmune disease that affects many organ systems. Spontaneous remissions and exacerbations characterize the clinical picture. SLE can be mild or aggressive and even life-threatening in presentation. The pathophysiology of SLE is best understood by a review of the diagnostic criteria. The diagnosis of SLE is made after 4 or more of the following 11 criteria are met in the absence of medications or other disorders known to induce these effects as defined by the American College of Rheumatology. So arthritis, non-erosive and usually involving 2 or more joints, photosensitivity, meaning the patient is often triggers skin rashes, exposure to the sun's UVB rays may be a triggering event for SLE exacerbations, oral or nasal ulcers, which are typically painless, a malar rash, which is a bilateral butterfly formation across the cheeks and nasal bridge, a discoid rash or raised red patches, sometimes with denuded central areas, serositis or inflammation of the pleura or pericardia, renal disease, or any one of the 3 indicators with proteinuria, 3+ or more proteinuria, or cellular casts. Hematological disorders, which could include hemolytic anemia, leukopenia, lymphopenia, or thrombocytopenia. We could also include neurological diseases like seizures or psychosis, which are not otherwise explained by iatrogenic or metabolic causes. The patient also likely will have positive ANA antibodies in your diagnostics. And then immunologic abnormalities, any of the 4 indicators, positive antiphospholipid antibodies such as anticardiolipin or lupus anticoagulant, antibody to a double-stranded native DNA, or false positive serological test for syphilis. So again, this is a tricky diagnostics, systemic lupus. The one thing I definitely would focus on in terms of systemic lupus is that malar rash, okay? That's really, really typical, bilateral butterfly formation across the cheeks and the nasal bridge. Again, look at page 1017 for your pathophysiology. Infectious disorders, so infectious mononucleosis, a viral syndrome characterized by prolonged malaise and fatigue, fever, sore throat, and tender, cervical lymphadenopathy. So again, one of your differentials for lymphadenopathy or enlarged lymph nodes would be infectious mono, or just mononucleosis, or mono, however you want to call it. Again, look at page 1025, table 63.1 for your infectious mononucleosis symptoms, as well as patient education. So important. Most of the patients who have this are usually younger, and they really need education, especially your high school students, as they should not be playing sports, because we are worried about splenomegaly. 50% of the cases of your EBV type mononucleosis will have splenomegaly. If they do have splenomegaly, they cannot play sports because they are at risk for rupture. So you need to make sure that they are excused from both the PE or gym, as well as any sports they are involved with for a period of time until they have a follow-up where their symptoms have diminished and they are no longer at risk for splenomegaly. We also have Lyme disease, which is a multi-system inflammatory disease caused by a Borrelia burgdorferi. And that's basically from a transference from ticks. Again, look at page 1029 in terms of your patient education and Lyme's disease. Here, in terms of infectious mononucleosis, I wanted to just give you a nice picture of what it looks like in terms of symptoms. We're getting fever, fatigue, sore throat, and most importantly, those swollen lymph glands. I remember when I was working as a school nurse, once a student came in, a high school student, a young guy, and he had this lymph node swollen, and he was so freaked out because the doctor said he had to work him up for cancer. And as soon as I knew this student, and I knew he had just gotten a new girlfriend, and I knew they were making out in the halls. And immediately in my head, I'm like, you don't have cancer, honey, you have mono. And both him and his girlfriend ended up having it. It is highly contagious. So you need to make sure that these patients are well educated on standard precautions and minimizing the spread of infection. In terms of infection, here we go with infectious disorders. And we definitely did readings on both HIV and AIDS. You're going to want to look at page 1049, table 63.4 for testing for the HIV infected patient with AIDS. And then you want to look at page 1053 in terms of patient education with acquired immunodeficiency syndrome for patients with active AIDS. Okay, so in HIV, we're looking at tissue dendritic cells, or Langerhans cells, are at the earliest targets of HIV infection. Once HIV infects the healthy CD4 T cell, HIV begins its replication activities. You want to make sure you're reviewing the Center for Disease Control and Prevention HIV classification system for adults and adolescents. You want to look at your clinical presentation, focus on the history and the evaluation of HIV risk of infection. You also want to look at your diagnostic tests for a newly diagnosed HIV patient. Keep in mind, more than 1 million people in the US are living with HIV infection, and about 15% of them are unaware of their infection. Although patients may experience a flu-like illness with acute HIV infection, many patients are asymptomatic for years despite having high levels of HIV in the blood and other bodily fluids such as semen. HIV infects key immune cells called CD4 T cells, leading to death of most of these infected cells. Over a period of months or decades, HIV kills more CD4 T cells than the body can produce, and the patient's CD4 T cell count begins to decline. When the CD4 T cell count drops below 200, the patient becomes particularly susceptible to opportunistic infections and is now considered to have acquired immunodeficiency syndrome. Table 63.2 in your textbook presents the CDC HIV classification system for adults and adolescents. So again, let me repeat that, guys, so you kind of understand this. So HIV is the beginning of the virus before it's actually active. Once the CD4 T cell count drops below 200, we are now active with acquired immunodeficiency syndrome, or we now actually have AIDS, okay? So once, that's the whole key thing, is to make sure those CD4 cells don't drop below 200. Once they do, that's when we're in trouble and we have full-blown AIDS. There is an HIV algorithm in your textbook on page 1041. It is fantastic. It really goes through the guidelines. It's a beautiful treatment flow chart for the management of early HIV infection. Again, it's so important that these patients are managed very, very early on. Now, in terms of screening for HIV, you want to look at your patients who are sexually active, any patients who are bisexuals or gays, your LGBTQ community. You want to really be screening them, especially if they are telling you they're having unprotected sex. We want to make sure these patients are diagnosed and treated very early on. Another clinical pearl I would tell you, if you have a patient coming in with a young patient, somebody late 20s or early 20s, 30s, even young early 40s, that comes in with sudden new onset shingles, especially the more severe case, the more you want to be concerned. These are patients you want to do HIV screening for, STD testing, but specifically HIV screening. Again, page 1038, the iceberg of living with HIV. So your book likes to do this thing called icebergs, and it's kind of like a concept map that they use within your textbook to review and point out all the components of what these particular patients living with this particular disease. In this instance, it's talking about the components of living with HIV, and now what the patient has to deal with and what they're going to have to manage basically going forward for the rest of their life. It's an excellent kind of concept map to kind of bring it all together and really look at your patient from a holistic standpoint. And keep in mind, you need to know all these particular pieces to the puzzle, because you as their practitioner will need to facilitate them getting the education and the support that they're going to need in all avenues so that they can manage this disease. So the things your patient is now going to have to deal with include pharmacological treatments, cost, and management of their medications. They're going to need education and learning about the disease, what the CD4 T cells are, what they need to know in terms of the numbers, and how or she now has to educate others in their life, specifically their sexual partners. They have to make sure they're educating them that they have HIV, that they're taking precautions, that their sexual partners have full disclosure so they know what they're getting themselves into with this particular patient. A lot of times you have to be very careful with these patients. They can be angry and then suddenly develop a vendetta and feel like, if they kind of want to hurt other people because they're hurt and infected. So again, you want to really screen these patients for these types of behaviors or thought process so you can really get them the support they need. They're going to need support groups, spiritual support, family support, mind, body care, self-care, and lifestyle changes. So they now need to be educated on awareness of safer sex practices, also needle exchange programs. That's a thing, if these patients, a lot of these HIV patients are drug abusers, IV drug abusers. So if we can get them in a needle exchange program, unfortunately, it's awful either way you look at it, but at least they're not spreading the virus to themselves or others. And also very important, you want to provide education to pregnant mothers with HIV, because these mothers need to know how they can decrease the risk of child transmission of HIV to their babies. All of these things are really important to consider. Please review this iceberg of living with HIV in your textbook. Okay, temporal arteriitis, also known as giant cell arteriitis. Very important. Make sure you review page 762, the plan in terms of pharmaceutical therapy. Keep in mind, giant cell arteriitis is an emergency. It affects the aorta and its large branches and vessels of the head and scalp. Usually the pain is there's pain to the temporal artery in the temporal area of the patient's face or head. It's raised and tender, and sometimes they'll even complain of vision loss, neck and jaw pain on the same side as the temporal artery that's being affected. You may also see some tongue necrosis on these particular patients. They will be positive for signs of systemic inflammation, including fatigue, fever, and weight loss. Temporal arteriitis is most common in women over the age of 55, and it's very closely associated with polymyalgia rheumatica, which we'll get into next. Complications of this, if it's left untreated, include an aortic aneurysm, stroke, and blindness. So these patients need to be sent to the emergency room immediately. This is an emergency, guys. So again, another name for it, giant cell arteriitis, temporal arteriitis, also known as Horton's disease or granulomatosis disease. I really have only heard it called giant cell arteriitis or temporal arteriitis. So in terms of polymyalgia rheumatica, very closely associated with giant cell arteriitis, also caused by inflammation, typically affects people older than 50, same thing as the previous slide said, and it often occurs in the neck, shoulders, and upper arms, this type of pain. So polymyalgia rheumatica is an inflammatory disorder causing muscle pain and stiffness around the shoulders and hips. Most people develop it after the age of 50. Sometimes this condition occurs with temporal arteriitis, a more serious condition that causes inflammation of the lining of arteries. Symptoms usually develop quickly and include aching of the shoulders, necks, or hips. Treatment is usually a low dose of an oral corticosteroid such as prednisone. Although treatment often lasts 2 to 3 years, most people start to feel better within a day or two. This type, polymyalgia rheumatica, tends to come and go and have exacerbations and remissions. So these patients, again, need to be followed by a rheumatologist. Then we have something called Raynaud's phenomenon. Here in this picture, you see this person's hands. You see the tips of the fingers are turning white almost. It's a problem that causes decreased blood flow to the fingers. In some cases, it also causes less blood flow to the ears, toes, nipples, knees, or nose. This happens due to spasms of blood vessels in those areas. And the spasms happen in response to cold, stress, or emotional upset. One of the things these patients tend to do is wear gloves pretty much all the time. It really makes a difference and helps with the discomfort of this. It can be very painful, Raynaud's phenomenon. All right, guys, that's it for this week in terms of review. Hopefully this was helpful. Next week, we're going to be in module 10 with neurology. You're going to be, you have assignments to read chapter 8 and 9 in your Dumpy primary care textbook and chapter 19 guidelines in CASH, as well as there's going to be a quiz for knowledge review. And I will post the review for the quiz from last week by Tuesday of this week, just so you can review modules. I guess it was module 8 quiz for cardiology. All right, guys, hope you have a great week and a very, very happy 4th of July. And I will see you next week. Please email me if you have any questions or you wanted to meet. Thank you.